All right, hi guys, good evening, good evening. I think I'm audible, I'm visible. Can you all see me? All right, so if you all can see me, can hear me, just give me a thumbs up. Today, we'll talk about another interesting topic in the esophageal series. I'll incorporate both the esophageal and the associated disorders here as well. So I'll touch a little bit on diaphragmatic components also. So one such disorder that we'll be talking about today is going to be your congenital diaphragmatic hernia. Today we'll be talking about the congenital. We talk about the congenital diaphragmatic hernia. We'll talk about the congenital diaphragmatic hernia, right? Again, a very important topic, a very conceptual topic, and I want you to understand that every single thing about this topic is going to be important from the exam point of view as well as from the clinical point of view as well, right? Okay, forgot to access the chat box. Just give me 1 second. Oh, chat box. Okay, I can see your chat now. Great. Now, when it comes down to the congenital diaphragmatic hernia, we will do it in our style itself. Just give me 1 second. Let me update all the colors that we have. Okay, can't do one brighter colors. Okay, fine. So when you talk about the congenital diaphragmatic hernias, I will be talking about in two different components. Just hold on for a second, guys. Some small issue. Just give me 1 second. Okay. Sorry, all glitch. But okay, now we're there. Alright, chalo. So let's begin. So we're talking about the congenital diaphragmatic hernia. I have two components of the congenital diaphragmatic hernia in which we'll be talking about, right? The first one would be your Bochdalek hernia. Another one is going to be your Morgagni hernia. Okay. So two components that we'll be talking about here. One is going to be our Bochdalek hernia. One happens to be your Bochdalek hernia. Another one is going to be your Morgagni's hernia. Uh, Guys, wait, is there some issue? Chat box is not getting access. Give me 1 second. Okay, fine. If you have anything, you're not able to get through, just comment on the chat box because I think my chat box is not signed in. I can still see the running chats there. Okay, any questions just posted down there. So talk about the Bochdalek hernia in comparison with that of the Morgagni's hernia. In comparison to of the Morgagni's hernia. Now, both of them is going to be a congenital diaphragmatic hernia, but you need to understand that among the two disorders that we are going to address it here, Bochdalek hernia is far more common when compared to Morgagni's hernia. 90% of your congenital diaphragmatic hernias are going to be your Bochdalek. Only 10% of them are going to be your Morgagni's hernia, right? So when it comes down to the congenital diaphragmatic hernias, any hernia, obviously the most important aspect is to understand where the defect lies, right? So we'll be talking about the Bochdalek first, and then we will squeeze it down to your Morgagni's hernia. So in general, when you're discussing about the Bochdalek hernias, let's look at the following component. Now, the first thing to understand in a Bochdalek hernia is its defect. Where do you think the defect is going to be present? So the classical description for the defect of the Bochdalek hernia, it is going to be a left-sided. It is going to be left-sided posterolateral defect in diaphragm. It is the left-sided posterolateral defect in diaphragm is the usual site, or I can say it is the most common site that you will see as a defect in the Bochdalek hernia. Now, many a times it just comes to you that how do you identify these defects and what is the exact objective behind it. Now, in order to understand the component between these two, you need to have a sound understanding about the anatomical orientation of the diaphragm per se, right? So when we talk about the whole orientation, let's take this as the representation of the diaphragm. Now I'm just going to show you to you this as the representation of the diaphragm, right? What I'll do for our understanding, I will divide the diaphragm dead in the center. So this will become the anterior and the posterior half of the diaphragm. So this will divide the diaphragm into the anterior half and into the posterior half. So you have the anterior half and the posterior half that is present, right? So when you talk about what are the various structures that you're going to look across it, or what are the various structures that can actually pass through them, right? So the posterior most structure that you can see here, I can say this is going to be the vertebra. For the sake of orientation, I'm going to depict the vertebra here. So this is the orientation of the vertebra. Let's say this is going to be your sternum, right? So your vertebra in the posterior aspect, sternum is on the anterior aspect that you have, right? So the posterior most structure that you're going to see, it is going to be slightly on the left hand side. So let's get that also into picture. So if I divide them dead in the center, which is here, we can keep this as the right side. This happens to be your left side, right? So the orientation is now clearly across here. So the posterior most structure that you will see is going to be aorta. It is going to be aorta. Slightly medial to it, or I can say in the center part, you have the esophagus, and then on the anterior half, you can say here, you can see you have the IVC, right? These are the three structures which are going to be present at the level of diaphragm, right? So you have esophagus, which is here, aorta, which is here, and IVC, which is going to be present across here. Now, when I say the defect of the Bochdalek hernia is going to be somewhere across here. It is going to be a left-sided. This is the defect of the Bochdalek hernia. The defect of the Bochdalek hernia is the left-sided, which is, as you can see, on the posterior side, it is the posterolateral surface. It is the posterolateral surface, right? So the defect of the Bochdalek hernia is going to be present on the left-sided posterolateral, and this actually during the embryonic development of the diaphragm, it fails to regress completely, so it persists. Now, if it is going to persist, what is going to happen? So when you talk about the pathophysiology of this particular disorder, so let's talk about the pathophysiology. Now, in order to understand the pathophysiology, I'll just give you a working component of this, right? Now, we're saying that we have a baby who has been born, right? Let's say this is the representation of the baby who is born, and let's say this happens to be the diaphragm that we are quoting across, and there's a defect which is present in the diaphragm, that is on the left-sided posterolateral defect. So during the embryonic development, you will see because of this defect, the part of the stomach which is present here, the part of the stomach will invaginate and occupy the thoracic cavity, and this is how it is going to present across. The part of the stomach, usually it is the stomach that goes in and occupies this area. Now, because of this, what is going to happen? The lung which is present on the left side is absolutely fine, or right side, but on the left sided lung will not be able to develop completely. So there is this problem that is going to occur, right? So as the stomach has taken across this area, it is not allowing this part of the lung. So this happens to be the right lung, this happens to be the left lung. The left lung is not going to develop completely. On the other hand, it is also going to push the mediastinum onto the other hand. It is going to push the mediastinum also onto the other side, right? So this part of the stomach that has come inside has caused these issues, right? So when you look at the issues, what are the problems you're looking at? Number one, because of the stomach invaginating, there is left-sided pulmonary hypoplasia. There is left-sided pulmonary hypoplasia. Now, along with left-sided pulmonary hypoplasia, you can see it is most commonly the stomach. It is most commonly the stomach which incorporates or which invaginates into the thorax and occupying the space. So it compresses that area. It sees the mediastinum is also going to be pushed on the other side. So it is a mediastinal shift is noticed, which is also referred to as the dextrocardia. It is your dextrocardia. Yeah. Right. The problem in the Bochdalek hernia is there is left-sided pulmonary hypoplasia. The stomach is taking that area, and then it is obviously there is also a dextrocardia as well. Now, how will this baby present to you? So, if you take this whole context into presentation, chalo. If we take into consideration, let's see how will these babies present to us. So, we talk about the clinical presentation. Now, these babies are usually going to present on day 0, day 1 of life. They can be diagnosed antenatally also, but let's say the baby is born with that. Okay. Now, what is the component that you will see? So, this baby who is born, because obviously one side of the lung is not developed completely and the other side is developed completely. So, you will notice there is only 1.5 lung for the baby to breathe. Now, because of that, the patient will present to you at birth with respiratory distress. So, this is a baby who is born with respiratory distress, right? So, at birth, the baby has this respiratory distress, and then you want to evaluate that, right? Now, obviously, day 0, baby is born, and as soon as the baby is born, the neonatologist is going to, appreciate what is happening. So, because of respiratory distress, I would like to auscultate, right? So, this is a baby who is born with respiratory distress, and this respiratory distress is because of pulmonary hypoplasia. It is because of pulmonary hypoplasia, right? Now, obviously, when you auscultate, you will see the apex of the heartbeat, which is supposed to be on the left, is now shifted to right. So, there is presence of dextrocardia. The presence of dextrocardia. Now, as the stomach has moved into thorax, this abdomen, which gives you the nice contour, it is because of filling of the stomach will not be achieved. So, because of that, it will depress, and that will result in scaphoid abdomen. That will result in scaphoid abdomen. So what do you mean by this is, normally in a newborn baby, we expect the abdomen to be like this, nice distended one, right? So let's say this is the newborn baby that we have. Normally we say in a newborn baby, you have a nice distended abdomen. That is because of the stomach. Now those babies who are having a Bochdalek hernia, you will notice there's a depression in the abdomen. Now that depression is because the stomach has invaginated. That is because the stomach has invaginated. See, the stomach has invaginated into the thoracic space. Now, this boat-shaped abdomen is what we call it as the scaphoid abdomen. Right? This is what we call it as the scaphoid abdomen. This is what we call it as the classical triad, which can be remembered as RDS of Bochdalek hernia. When I say the triad of the Bochdalek hernia, So when I say the triad of the Bochdalek hernia, when you look at the triad of the Bochdalek hernia, it is respiratory distress, dextrocardia, as well as scaphoid abdomen, Now, a very important concept here is, as soon as the baby is born with respiratory distress, right? Now you want to, comfort the baby, so you want to give oxygen. At the same time, you want to ventilate the kid as well. The problem here is, the minute you think about ventilation, think about bag and mask ventilation. Remember, as a very important note point, in a patient who is suspected to have a Bochdalek hernia, bag and mask ventilation, the bag and mask ventilation, bag and the mask ventilation is contraindicated. The bag and the mask ventilation is contraindicated. Now, why bag and mask ventilation is contraindicated is, if you take this as the representation of the ambu bag. Now, this ambu bag will be connected to the oxygen, and you obviously have the mouthpiece which is present here, right? Now, what is going to happen is, when you connect it to the oxygen and then you flush via the ambu bag, what is going to happen? Now, normally, if you look at the ambu bag, its capacity for adults is going to be 2 to 2.5. In adults, it is going to be 1 liter. It depends upon that. So, every time you compress it, it delivers the volume which is going to be equal to a tidal volume. Now, in this kid, you don't have enough amount of lung volume to accommodate. Now, for example, there's supposed to be two lungs, right? So, you have the right lung which is present here and the left lung. So, what is going to happen? This is the right lung, and this happens to be the left lung in which you are going to give the air. And today we know the left lung is not completely developed. There is left pulmonary hypoplasia. So this much part of the lung is not been developed. So when you deliver this much amount of air, half of it will go to right, the other half will go to left, but left does not have enough amount of volume to accommodate it. So that excessive amount of air will now go into the esophagus. From esophagus, it is now going to go into the stomach. Now, as it reaches the stomach, what is going to happen? The more amount of air goes into stomach, the stomach over distends. Now, that over distension of the stomach is going to worsen the situation. So, hence, bag and mask ventilation is contraindicated. So, if you look at from a standpoint, you'll understand that if this is a representation of the trachea, so this is the left and the right main bronchus, and let's say this is the right side of the lung and this is the left side of the lung which is underdeveloped. Behind this, you have the esophagus which is present here, which is going to run all across, and this is the stomach. You will notice that this is the esophagus, and obviously this is stomach which is invaginated here. Just for the sake of understanding, I'm just showing it across. The part of the stomach which is invaginated into the thoracic cavity, and let's say this is the diaphragm that we have, right? So what is going to happen, every time you are going to flush the air with the help of ambu bag, the air will go into the trachea, from there into the lungs. The right will accommodate, but the left will not be able to accommodate enough amount of air. So because it is less spaced out, whatever air that is going to be present, now because it cannot go into the trachea, now enters into the esophagus, goes into the stomach, and then the air will start pooling into the stomach. Now, as the air pools into the stomach, needless to tell you, the stomach is now going to distend even more, and this over distension of the stomach will only exert more pressure on the lungs, worsening the respiratory status. It is going to worsen the respiratory status. So hence, bag and mask ventilation is contraindicated in a baby of Bochdalek hernia. Right now, when we talk about the complications that it can land up into, so there are two complications. The complications associated with Bochdalek hernia. The complications that are associated with Bochdalek hernia. One, obviously, we have spoken about is going to be your pulmonary hypoplasia. One, it is a pulmonary hypoplasia, and second, it is going to be your pulmonary hypertension. The two complications that we know, one is a pulmonary hypoplasia, another one is a pulmonary hypertension. I hope everybody knows the reason behind the pulmonary hypoplasia. As we all know, the space is occupied by stomach, not allowing the lungs to develop completely. Hence, there is pulmonary hypoplasia. Now, why pulmonary hypertension? Now, let's understand and analyze in the same context, right? Now, take this as the representation of the heart. Right. Take this as the representation of the heart, and let's say this is the pulmonary artery to which the blood is being pumped. Now, just for the sake of understanding, I'm going to divide them into the right and the left pulmonary artery. To get the things sorted, I'm going to give into each individual lungs. Let's say this happens to be the right lung, and this is our left lung, which is hypoplastic, right? This is a right lung, this is a left lung. Every time the blood is going to come from the right atria, so this is your right atria, this happens to be your right ventricle. You see, the blood from right atria is going to come into the right ventricle. Now, as the blood from the right atria goes into the right ventricle, from the right ventricle, the blood will now go into the pulmonary artery. It is now going to go into the pulmonary artery. From there, the blood goes onto the right side of the heart as well as the left side of the heart. Now, imagine, just for the sake of understanding, 100 ml of blood used to come, just for the sake of example, 50 will go to right, 50 will go to the left. Problem is, if you just understand this small analogy, it will be easier for us to comprehend. 100 ml comes, 50 goes to right, 50 goes to left. The problem is, in you and me in general, we can accommodate 15 left. Problem now, there is hypoplasia. It cannot take that much amount of volume. So what is going to happen? Because the capacity of the left lung is less, it will not be able to accommodate the blood, so it is now going to back force it. Now you can see the heart is trying to pump the blood into the left lung. Left lung do not have enough amount of space, so it back pressurizes or it back pulls the blood. Now what is going to happen? The heart is trying to push the blood, whereas the left side of the lung is trying to put it back. But obviously heart, it is stronger. It will try to push more and more amount of blood. Now in order to overcome this resistance pathway where the left lung is trying to give the blood back to the heart says, no worries, I have a way to overcome this. What? Now this right side of the heart becomes bigger, right, so that it can contract with greater force, and this is what we call it as right sided cardiac remodeling. And this right sided cardiac remodeling is actually, you can see, as the blood is pulling back into the pulmonary artery, heart is giving, the left lung is giving, obviously the blood pools into the pulmonary artery, the pressure in the pulmonary artery will increase, resulting in pulmonary hypertension. This pulmonary hypertension, so as you can see, as more and more amount of blood pools, it will result in pulmonary hypertension. It will result in pulmonary hypertension, and this pulmonary hypertension will result in right sided, it will result in right sided heart remodeling, and this remodeling will result in death of the patient. It will result in the death of the patient. So when I say what is the early cause of death, remember the most common cause of death in a patient of Bochdalek hernia is your pulmonary hypoplasia. But if I say what is the cause of death after the age of 10 years, the cause of death after the age of 10 years is going to be a pulmonary hypertension. So two things that you need to know. At birth, what is the likely cause of death? At birth, the likely cause of death is going to be pulmonary hypoplasia. But at the 10 years of age, what is the likely cause of death? It is going to be your pulmonary hypertension. It is going to be the pulmonary hypertension, right? Now, once you have a fair idea about what is happening, let's talk about how would you evaluate. In terms of investigation for congenital diaphragmatic hernia, obviously because the baby is presented with respiratory distress, the first thing that I would like to do would be a X-ray. Rather than saying a chest X-ray, I'll get a whole X-ray done. Now on an X-ray, what do you find? There will be presence of air bubble. There will be presence of air bubble in left hemithorax. The presence of air bubble in left hemithorax. Now this is because of obviously the components moving here. So usually this can be formed by stomach. This can be formed by transverse colon. Very rarely it can have sometimes the small bowel as well. It can have small bowel. Another thing that you can have, rather than the air shadow, You can have other organ that can go inside this is going to be spleen. But if I say what is the most common organ, the most common organ that is going to herniate to result in the Bochdalek hernia, it is going to be stomach. Now in the X-ray, the other finding that you will see is going to be shift of the mediastinum. So there is presence of dextrocardia. So the air bubble in left hemithorax, there is presence of, right. So there is presence of air bubble in the left hemithorax. There is presence of dextrocardia. Obviously, that is also a very important sign that you will see on a X-ray, right? If I say what is the best investigation, then you can go ahead with the CT. CT will actually allow you to interpret things. So this is considered to be the best investigation that we are going to do across here, right? Now here in terms of management, one more thing, is there a clue in your antenatal diagnosis, right? So during an antenatal scan, or I can say prenatal scan, or I can say when you talk about the components here, one second, right? So during the antenatal scan, then the baby, during pregnancy, what do you see? During pregnancy, you will see presence of oligohydramnios, presence of oligohydramnios. So that's the Q point that you will see during pregnancy. Again, a possibility. Okay. Good night, Adya. So the air bubble in the left hemithorax, this presence of dextrocardia, CT is considered to be the best one. There will be associated oligohydramnios before birth. Management, again, prognosis is not that great, but if the baby survives, you can do a surgical management. The surgical management is basically to bring back the content, and repair the defect. It is to bring back the content and repair the defect, right? So these are the important aspects of your Bochdalek hernia. Right. So the whole component of the Bochdalek hernia is to identify where the defect is present. To talk about the Morgagni's hernia. Morgagni's hernia is easier for us to comprehend as well. So when you talk about the Morgagni's hernia, the Morgagni's hernia, again, the defect is what it matters. It is the defect that it is going to matter. So when you look at the defect which is going to be present here, it is going to be right-sided. It is going to be right-sided anteromedial defect. It's a right-sided anteromedial defect. This is also called as the Larry's defect or the space of Larry. Also called as the Larry's defect, or also called as Larry's defect, right? Now, when you look at the whole component, same analogy that we're going to have. Let's say this is the representation of the diaphragm. Let's say this happens to be the vertebra which is present on the posterior half. Let's say this happens to be the sternum which is on the anterior half, right? We divide it again dead in the center to tell you that this is antero-posterior. This is going to be antero-posterior, and this to tell you this is the left and the right side. Now, as we all know, same thing, the posterior most structure on the left side is going to be aorta. Anterior to it, but still posterior, is going to be esophagus, and then you have the IVC which is going to be present. The defect is going to be here. Now, if the defect is here, if the defect is here, which you can see, This is the anterior side, this is the posterior side. This happens to be the left side and this happens to be the right side, right? So it is right-sided anteromedial defect. It is going to be a right-sided anteromedial defect, right? So same thing as we can see in this context. The organs can herniate. Again, the most common organ to herniate. The most common organ to herniate here is going to be the transverse colon. It will be your transverse colon. Same, it is going to occupy the space. The baby will have a respiratory distress. But when you talk about the component on a X-ray, when you see on a radiograph, you see a retrocardiac. You'll see presence of a retrocardiac air fluid level. The presence of retrocardiac air fluid level. The management remains the same. The management is going to be to bring back the content. It is to bring back the content and repair the defect. It is to bring back the content and repair the defect, right? So this is with respect to Morgagni. So Morgagni, you just need to remember where the defect is. In Bochdalek, we should know where the defect is going to lie, right? So there are the two common components of the congenital diaphragmatic hernia that we should be knowing is, one is your Bochdalek hernia and the other one is going to be your Morgagni's, right? So I hope you understood the today's topic that we wanted to talk about. In this topic, in Bochdalek hernia, more important is how it is presented, how do you diagnose it, what are the complications, and how do you predict them in terms of your diagnosis, right? So this is all that you should know in the context of congenital diaphragmatic hernia, and that's it for today, right? So today we had a short session. I wanted to cover a small topic. Uh, Tomorrow we'll resume back. Tomorrow we'll talk about a very important topic that is going to be your esophageal perforation, right? Until then, so we'll start with the all the acquired disorders. So all the big disorders will start from tomorrow. Tomorrow we have esophageal perforation. Then we have the most important, the motile disorders of the esophagus. Once we're done with the motile disorders of the esophagus, then we will venture into tumors, and that will be the last part in the esophagus as well. Until then, thank you so much for joining. See you guys tomorrow at 9 o'clock. Bye.